36,000 boys, maybe 1 in 35,000 girls. And the theme is access for all, and women and girls bleed too. It's a really good caption. Some of us and most of the laymen, they think hemophilia is not seen in girls, or some of our colleagues think it's very, very rarely seen. Maybe true, but still they are underdiagnosed and undetected. So just to create awareness, understanding about hemophilia in girls and women, and as well about other bleeding disorders, this Hemophilia Day is being celebrated. So now our expert team will be, in nutshell, talking about the hemophilia and the recent advances like gene therapy or biologicals like emicizumab. So with these few words, I once again thank the faculty and all the participants for accepting our plea to be part of the faculty and to do this wonderful program. And this is available in YouTube. It will be, and it can be seen by many of our colleagues in future. So thank you once again, and over to Dr. Sridhar to conduct the program.
Thank you, sir. Thank you, sir, so much. And the concept of celebrating this World Hemophilia Day is to raise the awareness. So what to understand the hemophilia is, and also the breaking stigma, the reduced stigma and misconceptions to be decreased. So with these things, I invite all the faculty members headed by Dr. Sirisha Rani and Dr. Srikant Marda and Dr. Ramana Dandamudi. And now I request our RSV Sri Krishna to start the program with the faculty, introduce the faculty, and also start the program. RSV, please.
Yeah, Dr. Srikant, could you stop screen share? Yeah. Well, good afternoon, everyone, and a warm welcome to this celebrations online of the IAP World Hemophilia Day. It's a very important problem and a wonderful theme. And to tell us more about the theme, we have experts of hematology across the state of Telangana. I'm very glad to say that Hyderabad and especially Telangana state has expert care across all domains of pediatric health. And in the field of hemato-oncology, we have state-of-art hospitals and also experts who have got trained abroad and as well as in India. And they bring their insights and tell us more about the recent advances in hemophilia, and let us try to understand the genetics, the management options, and I'm sure it will be a wonderful learning opportunity for all of us. Yeah, sorry. Yeah. So, and to take this discussion forward, we have Dr. Sirisha, who's a consultant pediatric hemato-oncologist at Rainbow Group of Hospitals. And along with her are Dr. Srikant Marda, consultant hemato-oncologist with Ankura Group of Hospitals, and Dr. Ramana Dandamudi. And we also will be joined by Dr. Radhika, and if possible,
Dr. Varshini.
Yeah, Dr. Varshini. So now I'll hand it over to Dr. Sirisha, ma'am. If you could brief us on the magnitude of the problem, the extent, and why is it important, and why is IAP celebrating this day of all the other disorders, and then take forward the panel discussion. Looking forward to your session, ma'am. Over to you.
Thank you very much, Dr. Sri Krishna, and thank you, Dr. Sankosh Bhaskar and Dr. Sridhar and the entire Telangana IAP team to making us part of this program, academic program. As Dr. Sankosh Bhaskar already said, the magnitude of the problem is quite significant, as we all heard. And the incidence of hemophilia is to the tune of one in hemophilia A is to the tune of 1 in 30,000, 1 in 5,000, and B is to the tune of 1 in 30,000. So the magnitude of problem is huge. And for practicing
adolescent friendly health clinic madam. Hemophilia
so can you hear me?
Yes, ma'am. Yes, ma'am.
Yes, ma'am. Ma'am, I'll be muting all others. Request you to please unmute and then speak after I do this. Over to you. Yeah, please unmute and speak, ma'am. This way only the co-host can speak. Over to you, Dr. Sirisha.
Madam, unmute చేసుకోండి. Sirisha madam, unmute yourself.
Okay.
Yeah, please go
Oh,
ahead.
right. Sorry, sorry. I was just saying, like, the magnitude of the problem has been explained, and as we can see, the incidence of hemophilia A is to the tune of 1 in 5,000, and hemophilia B is 1 in 25 to 30,000. So the magnitude of the problem is huge, that when a practicing pediatrician is handling the bleeding child in OP or IP, so definitely hemophilia child do come across more frequently than any other bleeding disorder, as this is one of the common bleeding disorder. So, and as we know, it is an X-linked inherited disorder. So, which makes us more difficult when we are counseling the families, as we know the stigma of being X-linked disorder. So, that also we will address. So, we will go through various aspects, like how the bleeding manifestation changes according to the percentage of the uh, factor level available in the body, as well as we will also go through various bleeds, how to manage them, inhibitors, prophylaxis concept, how to manage. This is a chronic disease, as we all know, how to manage them in the at home, how to prevent it, and at the same time, what are the newer aspects, because we all know that medical field is moving forward so fast that for every disease, the newer aspects are coming up. So we'll go through these questions uh, in the presentation while in the flow. Dr. Shrikant, can you change the next slide? So as you can see, hemophilia inheritance is X-linked disorder. A carrier woman, when she marries healthy man, the chances of having hemophilia boy is there. At the same time, if there are two boys, then one boy will be hemophilia boy, the other can be healthy boy. At the same time, incidence of carrier girl is also, like, there for 25% for the offsprings of that family. Next slide, please. So, and if the woman is healthy and the man is hemophiliac, then both the girls will be carriers. As you know, the X will come from man, and both the boys will be healthy. Next slide, please. This is the slide what Dr. Sunkoj Bhaskar was mentioning, like, girls also bleed, girls also can get hemophilia. So when do girls get hemophilia? If uh, carrier woman marries hemophilia man, then X defective X will come from man, as well as carrier woman, one X which is carrying the gene also can pass on to one girl. So the chances of having hemophilia girl is there in that scenario. Or second scenario is if you have Turner syndrome, where the carrier X is there, but the normal X is not there. So that chances are also, like, you can get hemophilia. And the third chance is the lionization hypothesis, that is normal X will get inactivated. So in these situations, you can have hemophilia in girl. On the other hand, I should also mention that many girls at times, like, get treated as hemophilia. But if you actually check von Willebrand factor in those girls, it could be type 3 von Willebrand disease, where factor 8 also will be low. So these are the scenarios where you do see this problem. Next slide, please. So it's a royal disease. On the other note, like, one can say that it is a royal disease because it has been first detected in the royal family in London. So next slide, please. While to understand the disease more, we'll go through the questions. Dr. We have panel experts, Dr. Shrikant, Dr. Varshini, Dr. Ramana, and Dr. Radhika. Dr. Panita has sent her apologies for not able to attend this meeting. Dr. Shrikant, can you please tell us, based on the percentage of factor activity in the blood, how do you categorize them and how do they bleed? What are the nature of bleed they get according to percentage? And what are the important clinical features you do see in these children?
Yeah, at the outset, I will thank IAP PATS team for organizing this webinar. And thank you, Shirisha ma'am, for taking all the efforts in spite of not being in the country. So yeah, coming back to our discussion. So when we see the clinical features itself, how the child has presented, That itself, many of the times, indicates whether we are dealing with a severe form of a disease or a milder form of disease. Suppose if the child has presented with spontaneously with a bleed into the joint or an intracranial bleed spontaneously, we know that we are dealing with a severe hemophilia. Otherwise, if it is a trauma induced and then the hematorosis or hematoma formation is there, then maybe approximately we can think it is a category of mild to moderate. So that is based on the clinical features. But anyway, definitely history is very important. What is the age at which they are presenting? And what are the types of bleeds, especially the muscle bleeding, joint bleeding, or intracranial bleeding? It is not just the mucosal bleeding. We are dealing with the muscle bleeding, joint bleeding, and internal organ bleeding. Based on the factor percentage, if we want to classify, we can divide into mild, moderate, and severe, where we check the level of percentage of the factors. So for factor 8 being hemophilia A, factor 9 being hemophilia B, so we divide them accordingly. And if we have the percentage of the factor less than 1%, we say it is a very severe form of hemophilia. 1 to 5% comes under a moderate category, and somewhere 5 to 30 to 40% comes under a milder category. 1 to 5% is moderate, and 5 to 40% is a milder category. Anything above 40% can be taken as a normal, because 40% and above is sufficient for a normal hemostatic pathway. So based on the percentage, we can classify them accordingly.
So, absolutely, Dr. Srikanth, as you have already mentioned, can you please go through slides like, when I'm just summarizing what you said, as Dr. Srikanth has already mentioned, the mild, moderate, and severe, according to percentage of activity mentioned here, and Dr. Srikanth elaborated, the bleeds varies. So mild definitely will not bleed unless otherwise there is a trauma. Severe and moderate definitely bleed. Severe definitely spontaneous. Moderate spontaneous but trauma induced. This is how we see. Next slide, please. So these are the various bleeds: knee bleed, bleeding from cut site, bruises on the skin. So I should say that, currently we are diagnosing hemophilia. In the past, hemophilia usually for bigger children like 4 5 years or so. But nowadays we are seeing infants also coming in less than 1 year age and getting diagnosed as hemophilia, because most of the parents are becoming, whether it is they are becoming more observant with bruises itself, they are coming up. Otherwise earlier it was more of joint bleeds. With joint bleeds they used to come. That is one observation in the clinical presentation what we have seen differently compared to past. Next slide, please. Rakshikant, next slide, please.
Just got stuck up.
Oh.
Yeah.
Yeah. Dr. Radhika, can you please tell us what are the consequences of bleeds? Why do you take them so seriously? Or why do you have to control? Of course, if it is bleeding from external parts or volume loss, you do worry. But for into muscle, into joint, why are you so aggressive? Why do you want to control the bleed? Can you please elaborate on that?
Thank you, Dr. Sirisha. Thank you for the question. So it's important that we control the bleeds and not prolong it for a long duration of period, because majority of the times, most of the times, 70 to 80% of the times, the drama of hemophilia is all about hematorosis. So most of the times you get bleeding in the joints and all. So recurrent bleeding in the joints can release, whenever there is a blood in the joint, which is an abnormal site, the blood at the abnormal site, they release some kind of interleukins, cytokines. They cause some inflammation and inflammatory damage to the synovium, to the cartilage. As a result, the joint space comes down. So because of all these reactionary or inflammatory changes, which happens in the joint because of recurrent bleeds in the joints and all, on a long-term sequelae, it kind of causes joint damage, and it kind of decreases the mobility of the joint, causes a chronic pain in the joint. It causes the wasting of the muscles around the joint, and overall it leads to a chronic hemophilic arthropathy. So the joint ultimately becomes damaged and the patient becomes crippled. He becomes physically handicapped. This is the most common presentation of hemophilia, that is the chronic arthropathy, hemophilic arthropathy, but otherwise You also can find some of the distressing consequences with bleeds in other areas. Like sometimes what happens is if the patient bleeds in the muscles, especially in the muscles near the joints, like in the thigh and somewhere in the uh, thigh, especially the thigh regions and all, when there is a bleeding in the muscle, the bleeding can become organized into an organized hematoma and form a pseudotumor. At times, the pseudotumor can be so very distressing that it can cause compression, compartmental syndrome, nerve compression, etc. and all, to an extent that we may even need to go for a surgical correction. So these are the two most common long-term sequelae. So chronic hemophilic arthropathy, the pseudotumors, some of the bleeds which occur in the CNS threatening, they can cause some neurological deterioration and all. So that is why it's important that an acute bleed should not be taken very light. We need to be aggressive on managing the acute bleeds and try to get away with it at the earliest possible, because the more you prolong the bleed or the more recurrent a bleed occurs in sites and all, on a long term, it leads to that particular site damage, a joint damage or a pseudotumor or a neurological deficits and all. So it's important that we take every bleed very cautiously.
Thank you, Dr. Radhika. So thanks for elaborating like how the joint damage progresses and can lead to even joint replacement surgeries. We have seen some of the kids who grow into adulthood as a young adult, they know some of them they undergo joint replacement, which is distressing as we all know. And at the same time, how the muscle loses function, fibrosis, pseudotumors, cord compressions, compartmental syndromes, all these things can occur. So hence every bleed has to be treated very seriously, except mild skin bleeds, mild bruises. At times we do observe that. So moving on to next question, Ramna sir, I think he's there in the panel. Sir joined, right? Yeah. So, sir, how do you manage bleeds? What are the challenges in the past? You have seen like how scenario has changed in the past compared to now. Can you please elaborate on that?
Certainly, any moderate to major bleeds, they need factor replacement immediately. As a short period, less than 6 to 8 hours, ideally would give good response. And then regarding when we want to treat, we look at exactly the type of bleed. And the second thing is how much it would require the factor dose and duration. Okay, because we all know that this factor 8 or 9 is now very specifically is, produced. If we take historically nearly 30-40 years back, we used to use FFP cryoprecipitate as a blood products, but that's the past era. Now we have so many kind of advanced factors available, and then more and more monoclonal antibodies, and then we are getting into the other newer technology and gene therapy. So ideally, how I look at it, there are 4 steps when we are trying to deal the family with hemophilia. First step is we need to, kind of aware them, make abundantly that they understand what is hemophilia. Second thing is when they need to attend the doctor or hemophilia treatment center for the factor administration. And then, kind of how long, these are all very important. So ideally, as they have very good awareness that they need to be given very good material about uh, the disease treatment and developments, and also trying to conduct small meets among the parents, among with the professionals. And then you have that the factor replacement therapy. Now we got initially plasma derived. Now is we have the kind of newer factors available, and then we work it out. If it is factor 8, each unit rises 2%. If it is factor 9, each unit rises 1%. So depending on the type of bleed, you calculate the dose and duration. So
Thank you, sir.
certainly they followed by, it's kind of initially you do first aid, that is some criteria like RISE technology, and following the bleeds also, they would require some prophylaxis to, keep the joints and muscles healthier with physiotherapy. Physiotherapy also is very important point.
Absolutely, sir. So, starting from price, then factor replacement, then how to prevent the further bleeds. While giving the factor replacement, we need to be very careful in where the bleed has happened. If it is joint, minimum of 3 to 4 days, we end up giving the factor. Then only the joint function bleed will get controlled, and then child will be able to walk normally, and joint function will get restored. And to prevent further bleed, of course, as sir mentioned, you have to go ahead with the physiotherapy, so that strengthening of the muscles around the joint definitely will help in preventing the further bleeds. And if it is IC bleed, ileoceous bleed, meticulous way of handling, like at least a factor percentage to the 100% in first few days, and then gradually tapering and maintaining adequate factor percentage for a week, and followed by prophylaxis aggressively. So these things will prevent the repeat bleeding in those areas. Otherwise, it will attract the rebleed and then can cause the permanent neuro disability. So we have to be very careful in handling the CNS bleed, and at the same time, we have to be aware of, one factor therapy will not be enough for joint or muscle bleeds to control the bleeding in those areas. Next slide, please. Dr. Parnita is not there. Dr. Varshini, if you has joined, can you please take up the question? I think Dr. Varshini, we informed in last minute, I think literally 5 minutes ago. That's why she was busy in the OP. Maybe Dr. Radhika can take up this question. Radhika, can you please address this? When do you suspect presence of inhibitors and how do you check?
Yeah, sure. So there are certain scenarios where you need to suspect the inhibitors and then you go ahead evaluating for the inhibitors and all. So basically in our regular clinical practice, certain time points, like if a patient who has been responding previously well to the factor VIII concentrates and now he's showing a suboptimal response, that's when you suspect that probably you're dealing with an inhibitor development. Second thing is, if the patient previously was requiring certain amount, like 1000 IU for every blade, and now he's requiring a higher dose, that's when you suspect that probably inhibitors. Before going ahead with any surgical intervention, you need to do the inhibitor testing and all. Otherwise, you will end up in soup. These are certain indications where you suspect clinically that probably the patient has developed inhibitors. Otherwise, also there are certain time points where you have to regularly do the inhibitor screening. Like in the first 20 exposure days, you have to do the screening every 5 exposure days, and then every 10 exposure days from 20 to 50 exposure days. After 50 exposure days, you got to go on repeating inhibitor screening annually or biannually, something like that. So certain time points you invariably have to do and pick up incidentally or accidentally. And there are certain points where you suspect clinically and go ahead with inhibitors. So whenever you suspect, the first thing what you have to do is we do an inhibitor screening test, an APTT-based screening. If the screening comes positive, then we do analyze the quantitative assay by Bethesda assay. So this is how we suspect and go ahead further for testing for inhibitors.
Yeah. Thank you, Dr. Radhika. So as you rightly mentioned, whenever we get the suboptimal response to adequate factor therapy to the concerned bleed, then definitely we have to go ahead and suspect the inhibitors and then go ahead and check it. Though we don't check as frequently as it is recommended, we all know that in India we do have to go ahead and to cut down the cost, we do have to go ahead and modify the recommendations. So going by that, though we don't check that this frequently, definitely whenever there is a suboptimal response, whenever there is good number of exposures, and the most important point Dr. Radhika mentioned is before surgery. Because if the child has been taken up for surgery and bleeds on the table, then it's very difficult. So before surgery, and you are giving pumping in factor VIII, but no response, so that is a disaster. So before surgery, definitely you have to go ahead and check. So these are the indications when you check the inhibitors, and inhibitors are more frequent in factor VIII compared to factor IX. And there are ways how to treat the inhibitors. So Dr. Srikanth will elaborate on how to manage the inhibitors in a child with hemophilia. Dr. Srikanth, over to you.
So once we know that we are dealing with a child with inhibitors, definitely it's not a easy situation to handle. Uh, Firstly, we need to classify whether they are low responding inhibitors or high responding inhibitors based on the modified Nechmek and Bethesda assay. If it is less than 5 units, then we say it is a low titer inhibitors. And if it is more, the value is more than 5, then we say they are high responding inhibitors, because the treatment definitely varies in each of them. And then there are few risk factors as well who can develop the inhibitors. So we can look at the risk factors as well, like severe hemophilia A generally tend to have more severe inhibitors compared to a moderate hemophilia A. And then having larger mutations, like large deletions or intron deletions, intron inversions, they have more tend to have inhibitor formation. And if there is a family history as well, so we know that these children have a more tendency to form inhibitors as they progress along. So accordingly, keeping the risk factors, once we have divided them into the category, we need to treat them. A low responding inhibitors definitely would settle down if we give a higher dosage of the factor per se. And because many of the times over a period of 6 to 8 months, uh, even the low titers can become negative as well. So they can be slightly easily managed. But when we come to higher titers, they are the ones which who are difficult to manage. So we have multiple modalities of treatment in them. Here, we know that the factor per se will not be useful at the regular dosages. So we'll have to give higher doses, and that too as a continuous infusions. So main principle behind this, so that is what is known as ITI, immune tolerance induction. So on giving a higher doses at a continuous rate, we are ensuring that the antibody formation is not being happening in our body. So the continuous level of the factors is being maintained above 1%, at least we want to target that. So by maintaining a continuous good level of the factors, we are ensuring the antibody formation is not there. So which is the principle of ITI. And then apart from ITI, the other agents, especially the FIBA, that is factor VIII bypassing agents, these are available and these can be used, and these have to be used in cases of high titers. We have the PCs and APCCs, that is prothrombin complex concentrates and the activated prothrombin complex concentrates, and Novo 7 as well. So that is the recombinant factor 7, which also can be used. So these are related to the factor which we have available. Apart from that, nowadays we also have the monoclonal antibodies which can be used in cases of severe hemophilias with inhibitors like emicizumab, which has been a wonder drug. And then based on the protocol, what we are following generally, because we are in a low source income countries where the factors are not easily available. So then we have to uh, think of a lower factor administration. But there are other protocols like Malmo protocol, where higher dosages of the factors have been administered along with other medications as well. So we can use medications like steroids or rituximab, cyclophosphamide, which are given together along with the factors. So giving high dose of factors along with these immunomodulation therapy will help us in handling the difficult situation of a higher titers, because they are prone to have higher incidence of bleeding as well.
Yeah, Dr. Shrikant, thank you for elaborating how to, Dr. Radhika said how to when to suspect and then how to manage. You have elaborated in detail. So one is during bleeding, as you mentioned, factor 7, FIBA, APCC, all these will control the bleeding. And of course, further, you want to address ongoing inhibitors presence in the with the immunomodulators, what you have already mentioned. And of course, as you said, like, a wonder drug has come. So going by that now, we are all moving to that. I think we'll come to that next in subsequent questions. Dr. Vashni, can you please tell us, like, what is the concept of prophylaxis? So, of course, before emicizumab, we were all like, this was one of the savior for the hemophilia kids. factor prophylaxis. So can you please elaborate on this?
Yes.
And even now we are using for some of the kids, as you know. Yeah.
Good afternoon, everyone. So, prophylaxis, especially in severe hemophilia, is a really life-saving methodology, I would say. So, the main concept is to make the severe hemophilics into mild to moderate form so that the number of bleeding episodes, spontaneous bleeding episodes, and major bleeding episodes will be reduced, especially in young toddlers, head injuries, and all these things can be prevented also with this prophylactic management. So this again prophylaxis is divided into continuous or intermittent prophylaxis. Continuous prophylaxis can be primary prophylaxis or when there is absolutely no joint bleed happen. Before that only we can start. There is no age criteria for that one. And secondary prophylaxis is after one or two joint bleeds. Before any joint disease has established, we generally start them on prophylaxis. And the tertiary prophylaxis is after establishment of any joint disease. So Western world will give a little higher dose of prophylaxis, but in our lower middle income countries, we give low dose prophylaxis generally twice a week, 2 to 3 times per week, 10 to 15 international units per kg we do give. So this will generally prevent major bleeds and recurrent joint disease. It will improve the quality of life and musculoskeletal system abnormalities will be reduced and they have a better lifestyle when compared to on-demand receiving of factor therapy.
Thank you, Dr. Varshini. So, prophylaxis concept is still active, especially in the places where emicizumab, cost of emicizumab, as we know, is high, despite patient support program where they do get free vials. But in government sectors, like as we know, factor is easily available. So, prophylaxis can be given through government program free of cost for the kids who are in need, who like severe or moderate with significant bleeds. Prophylaxis concept is still active. Dr. Varshi, can you tell, like, some of the parents will ask, like, by giving continuous prophylaxis, so are you not increasing the risk of inhibitors? So that is one of the question that will come up. So how do you address that?
Formation of inhibitors is less on prophylaxis. When we give higher factors, then the risk of formation of inhibitors is more. So especially during on-demand, when there is severe bleed, we give higher concentrates of factor, which will lead into the inhibitor formation. So prophylaxis really doesn't have any impact on the inhibitor formation.
Very true. Yeah. So prophylaxis with low concentration definitely reduces the risk of inhibitors and improves the quality of life, as mentioned earlier. Dr. Shrikant, can you please move the slides? Next slide, please. Yeah. Sir, Ramana sir, as we all know, this is a chronic problem. So we have to train the families. We need to go ahead and manage them at home. So can you please elaborate, like, how to manage them at home?
Actually, if we look at the hemophilia treatment, services were vertically placed 10 years ago. But as the factor is available freely now, that's a live factors, whether it's a plasma or recombinant factors. And then more and more we getting into the horizontal services, whether establishing more sub-centers. Suppose in Telangana, we have nearly 2,300 hemophilia patients. In that, used to be only the Hyderabad city used to serve all these patients. So wherever they are, they needed to come over to the city and have the treatment. But with a lot of initiation from the parental side and government side, now we have nearly 13 to 17 centers across the state of Telangana, where factory is now available at free of cost. But that doesn't mean, because we need to look at certain things like ultimately the quality of care, okay, and also addressing uh, the school absence, work absence, so many other things. What it is ideal is to kind of train the families for self-administration, either by the parents if the children are very small, if they are teenagers and older, we can train them for self-administration, but they should have a good idea about the disease, the type of bleed, basically the site and the quantity of the bleed and how much factor they would require still, because kind of now with a lot of advancements in the treatment of hemophilia western world, they are going intermittent therapy, like the one of good drug is emicizumab, but I think we still need to continue for the factors for some more time. So if we train the family, give them adequate information, this works out very well. And there are quite a good papers coming from the Indian physicians about home care team, because it basically it reduces a lot of traveling, and then they can get a factor immediately after the bleed, and also it's a good way of doing for prophylaxis.
Yeah, so absolutely, sir. Well, as we know, to reduce the work absenteeism, school absenteeism, training the people how to manage at home is very important. In Western world, hemophilia team goes home and then they used to train. When we were doing our training in UK, we used to feel that, that's an amazing job. However, now they do need to do that because many of their kids are in emicizumab. But in our country, this home management has to be active still because many of our kids are not on emicizumab. Some of our kids are on emicizumab. Going by that, we are in more need of these activities like home to teach them how to do manage the child at home. So this is very important. And regular exercise definitely helps them in controlling the number of bleeds, so that your quality of life will be better for them. Next slide, please. Next slide. So, Dr. Radhika, we know that now newer agents have taken over quite significantly over the whatever we were practicing in the past. So, can you elaborate on newer agents like which are useful in hemophilia?
Yeah. So we all know that today the standard of care in hemophilia is prophylaxis, but prophylaxis has got some unmet needs. It has to be like if it is factor VIII molecule, it has to be taken every alternate day, 3 times a week, factor IX twice a week, which is not really comfortable, and it kind of hampers the quality of life of patient. So we need more better manuals and all. So basically the researchers have gone ahead and they did lots of experiments and all to come up with molecules better than what is existent today. The first and foremost thing what they did was a pegylated molecules. So they found that they thought that what if I can expand the half-life of the molecule, where I was giving like thrice a week, what if I can give once a week or once in 2 weeks? The quality of life of the patient could be very much hampered. So this particular logic was put in, and then came up, and then molecules like pegylated molecules have come up, like pegylated factor VIII or pegylated factor IX, wherein a molecule like an FC component or an albumin or some pegylation was conjugated with the existing factor VIII molecule, increasing the half-life. So today we have newer molecules like pegylated factor VIII or long-acting factor VIII and long-acting factor IX. The long-acting factor VIII did not do much magic because it could only enhance the half-life little bit, where we were giving the factor VIII prophylaxis like twice a week or thrice a week. With this long-acting molecules, we were able to give once in 5 days. So that was not a great improvement. But if you take the pegylated extended factor IX molecule, where we were requiring to give the molecule prophylaxis with factor IX once every 5 days or twice a week, now with that newer molecule, we were able to give prophylaxis once every 2 weeks. So though the factor VIII pegylation did not create a much magic, but the factor IX pegylation has come up with a molecule which is like kind of like significantly improved over the existing. So that is one way of improving the molecules by attaching a pegylation or whatever. The second way was, even if we have an extended molecule or pegylated molecules which were increasing the half-life, still there were some unmet needs. Still the patient was requiring an IV infusion, which at times may be challenging, especially for small children. And always the molecules, the concentrates, always carry a risk of immunogenicity. So as long as you're giving factors, you always carry a risk of developing inhibitors. So how can we like curb these particular unmet needs and all? So again, the researchers have come up with newer molecules like mimetics or like rebalancing agents. These are actually not concentrates. They mimic concentrate. They're molecules, so they don't have an immunogenicity. They don't carry the risk of inhibitors. These are molecules which does not require to be given by IV infusion because the route of administration is subcutaneous. So whatever unmet needs we were having with the factor molecules, they were curbed or they were overcome by these kind of molecules which are mimetics or rebalancing agents. So we have a breakthrough molecule today in the market, the emicizumab or Hemophilia, which is breakthrough in the sense that the route of administration is subcutaneous. It has a very half-life. You can give it once a week, once every 2 weeks, or even once a month. It does not carry the risk of immunogenicity because it's not a factor concentrate, and then it has a higher efficacy when compared to the existing factor molecules. So this is right now like ruling the hemophilia arena. However, there are other molecules also which are coming up in the pipeline, like Hemophilia is only for prophylaxis. So in hemophilia A, for patients with inhibitors and without inhibitors. There are other molecules like concizumab by Novo Nordisk, which is soon coming up, likely will be coming up by the end of this year. So this is also a monoclonal antibody. It can be useful for patients with hemophilia A and hemophilia B with inhibitors and without inhibitors. There are some drawbacks, there are some advantages. We'll get to know as the molecule comes into the market. Fitusiran is also a good molecule, which is also in the pipeline, in the final stages of its clinical trials. Very likely by this year or next year, it will be in the market soon. So these are some molecules. Still, we are human beings. They're not happy. We don't want to take treatments. We don't want subcutaneous. We don't want IV. We don't something like a permanent cure and all. So the next thing, what we are looking forward, probably in the next 2 or 3 years, or 3 or 5 years, is a gene therapy. 1 or 2 injections, and you are done with hemophilia. No more injections and no more all this drama of bleeds and all. So these are the newer things which are in the pipeline, and very soon we'll be looking forward for all this.
Thank you, Radhika, for elaborating. So, 2.5, 3 decades ago, FFPs, then on-demand therapy, then concept of prophylaxis, 2 to 3 weeks, 2 to 3 times a week. Then subsequently pegylated form has come up, and then beating all, like, emicizumab has come into picture, knocking out other things aside. Emicizumab has come into picture, and then we, as Dr. Shrikant also mentioned in the beginning, it is a wonder drug. So we all know that it is working excellent. So we will hear one sentence, 1 or 2 lines in there, like how many patients have been managing. So from my side, I will say, like, we have in our Nilofer, like Dr. Usha is running a program where emicizumab is given free of cost. So we enroll some of our patients into that program, and some of our patients, around 12 to 13 patients, they are taking on their own with their own expenses. So all of them are completely bleed free with or without inhibitors and leading completely normal quality of life, which is an excellent drug. So uh, our personal experience is that. So that is one thing. And other than that, Dr. Radhika mentioned like gene therapy. Yes, in adults, it has been like, completely definitely proven that, it works. In children, trials are still ongoing. In adults, um, it will not cure the disease, but it will convert once again, like, severe hemophilia into mild, and then number of bleeds will come down, quality of life will improve definitely. So the pros and cons are there for gene therapy. That's a different thing, but definitely, it is also coming up in pipeline. Now I request all the panelists to mention one sentence, a couple of lines about their experience with emicizumab. But Dr. Vashini, can we start with you?
So as you already mentioned, ma'am, so we have 10 to 12 patients who are privately purchasing the drug and then taking, and one child even with the bad joint disease who have been enrolled in ESI and taking, and then now the joint bleeds have significantly reduced, and this with therapies, then now he was wheelchair bound. Now he is able to walk after starting emicizumab with aggressive exercises and everything. Now he started walking better. So mother is really happy. She was very reluctant to take it. I had to convince them a lot. Then she went back and then spoke in ESI, and then she started. Now she's really happy. And even low dose. So we even tried for a couple of kids who are very weight. So low dose therapy also rather than recommended. Even they are doing good. So I think it has really made a lot of difference in the lives of these kids. Probably government should come with some subsidies or something
More
for
support. Yeah.
these kids.
So very valid point you have brought up, like, low dose, because in India we always have modifications because to cut down the cost. So though it is recommended 1 to 3 per kg, we give just 0.5. Some of them with the higher weight, 0.3 per kg is also, like, it is working very well, but very low, just 10% of recommended dose when we are giving also it is working. That is what is surprising. And when we pull the data in from India, definitely we can we can publish and make the Western world realize that even low doses also how it makes a difference in these diseases. So Dr. Radhika, yeah, definitely you will have experiences like this. Can you please share in a couple of lines?
Yeah, I do have experience with emicizumab. Actually speaking, the first patient in the state of Andhra Telangana was my patient only. The emicizumab started in the state with us, so I always carry that cap with me. So we have around 12 patients on emicizumab. Most of the patients who are with us are all credit patients, EGHS, ESA and all. So I don't compromise the dosing and all because I need to go as per the guidelines. So I give the regular dose of 3 mg per kg, weekly once loading dose followed by every 2 weeks maintenance dose. I don't compromise. I do not have any patient whom I have put on low dose prophylaxis, except for some on pocket patients and all, 1 or 2 off label. But all my patients are on the regular recommended doses, doing perfectly good, no breakthrough bleeds at all. This is a wonder drug. Recently, we have done a surgery also on one patient. He was requiring a hip replacement. No. He was requiring a robotic nephrectomy surgery. So 3 months prior to surgery, I have put him on emicizumab prophylaxis with Dr. Vikram. And on that prophylaxis, I brought in a hemostatic stability. With that hemostatic stability, I took him up for robotic surgery, nephrectomy, with factor 7 coverage because he was a patient with inhibitors. And then successfully, the surgery was so uneventful. It went on as if like the surgery was being done on a non-hemophilic patient. So it's a magic bullet.
Yeah, very good point you brought up. So obviously when it is coming free, then definitely you can give adequate dose. When it is not free, then you have to compromise on the dose. And I should say that, compromising the dose, we checked with entire PHO group, pediatric hemo group, and we were surprised that everybody is doing the same kind of, practice. They are giving very low doses. Delhi group is about to publish their data. So they also said that, even 0.3, 0.4 per kilo is also working very well for them without any breakthrough bleeds. That is one thing I want to say. Another thing is, like, we also did one IC bleed surgery, as Dr. Varshan can recollect. So one child we operated with IC bleed, went through evacuation, later even shunt replacement for hydrocephalus. So it was just cakewalk when he was undergoing the surgery for the shunt placement and all. So that is one thing we want to share. Dr. Srikanth and Ramna sir, can you please add to your, emicizumab experience in your clinical practice? Dr. Srikanth, are you there?
Srikanth, unmute yourself and please. Unmute yourself. Yeah.
Yeah. Personal experience of myself with emicizumab is not there because we divert them to the sector where it is available freely because the cost is being high, so they cannot bear it unless if they are provided at abridged prices. So we have diverted a couple of cases to ESI hospital under Dr. Vikram. So he had treated them.
Okay, Ramana sir, can you please add?
Sir, madam, I am unable to see Ramna sir.
Okay.
Already, I think he kept a
Okay,
message.
sir. Okay. Yeah. So one question, one thing that always come to our mind is when we are counseling the family. with hemophilia. Recently, I have come across. That's why I want to share this experience. A family who lost kids in the past with abortions has conceived, and then mother is a carrier for hemophilia, and this is a boy, because whenever mother is carrier, they do reveal, whether it is boy or girl. So when they were in dilemma whether they want to continue the pregnancy or not. So there, as per recommendation, we have to tell them to go for the antenatal diagnosis and then to continue pregnancy. But at the same time, family was not ready for abortion, though it turns out to be hemophilia. So as a doctor now, with the in the emicizumab era, whether we say that okay, continue or not, is an individual physician choice. We have to tell them, yes, there is a drug which you have to take once a month, once in 2 weeks, as per the recommendation, or once a month also. Haven 4 trials says even once a month also effective. So once a month, one subcutaneous injection, they continuing the for lifelong, and then they continuing pregnancy is, makes sense rather than, going for abortions, especially in a family where the pregnancy is precious pregnancy. That's what, it's always a clinician dilemma. Just want to share that. So I think we have come to the end of the session. Uh, as we have seen, hemophilia was one of the life-threatening disease with IC bleed incidence is being there in the past. Suddenly, if they get into IC bleed, that is is going to be a big disaster in the past. And then with joint bleeds, muscle bleeds, disability was one of the risk factor being always there. But at the moment, with the wonder drug emicizumab has come into picture, hemophilia A is significantly manageable, but B is definitely a challenge because concizumab is there to control the hemophilia B, but at the same time, it is not available in India, though it is licensed. So it is not yet available. Hopefully, very soon it should be available. As Dr. Radhika also mentioned, it should be very soon available, and then should be able to manage even B just like A, so that we will have good quality of life for that subgroup of hemophilia patients. Thank you. Over to Sridhar sir.
Yeah, thank you, ma'am. Excellently moderated by Dr. Sirisha. And special thanks to Ramana sir and Srikanth and Varshini and Radhika, who had really, our central IAP madam is showing more interest in these particular days, and to bring the awareness and also education, outreach the things. So in that way, the PATS is committed, and our under the leadership of our Sunkoj Bhaskar sir, we are very much committed and do these type of days whenever the requirement is there. Definitely we'll take your help, and any workshop also, the like bleeding disorders or any hematology workshop also, we'll take definitely your experiences and your things, madam. So a
Sure.
special thanks to all the faculty. And before closing, Sunkoj Bhaskar sir, any words from you, sir?
Yeah, my special thanks to the faculty, particularly Dr. Sirisha Rani, Dr. Rama, Dr. Varshini, Dr. So all those faculty were informative and educative. I'm sure many people are going to see this through YouTube. So thank you all once again, and thank you all the participants for being with us during this afternoon, postprandial drowsiness. Anyways, thank you very much. Thank you.
Sirisha madam, Sirisha madam, ఇది
Thank you, sir.
యూట్యూబ్ లో ఉంటుంది మేడం. యూ కెన్ ఫార్వర్డ్ ద సేమ్ లింక్స్, అండ్ యూ కెన్ ఫర్ ద పోస్ట్ గ్రాడ్యుయేట్స్ అండ్ ఆల్ ద డిఎన్బి పీపుల్, యూ కెన్ సెండ్ ద సేమ్ లింక్స్ మేడం. ఓకే, యూ కెన్
Definitely,
షేర్
sir.
ద లింక్స్.
Yeah.
Thank you
Sure.
one and all.
Thank